titled So You Want to Do Rural Mobile EMS Simulation, presented by Jonathan Carolla. I'm going to pass it over now to our presenter. Jonathan, thank you so much for being here with us today to share your knowledge and experience with us, and we look forward to the presentation.
Thank you. Happy to be here and happy to be back presenting. So today we're going to be talking about simulation and how to set up rural mobile simulation in EMS and some of the tips and tricks that you have with it and some of the things that kind of hard with it. This is really going to focus on EMS agencies that are wanting to up their education game, but they may be in a more rural environment or they may be kind of low funded and they kind of have to make things up on their own and kind of go from there. So that's kind of going to be a little bit how today goes. I'm a very interactive speaker, as we'll soon learn here in a little bit. If you've attended any presentations I've done or a webinar in the past, you guys will see this too. So please, as questions or comments come up in the chat, please feel free to put them out there. I want to see you guys networking and talking together, and I will answer questions that come up in the chat as they happen. And this will be a lot more engaging and you'll get a lot more out of it if we can do it that way. So let's go ahead and get started. So some disclosures. I have no financial disclosures or product endorsements. However, if anybody is wanting to finance me, I will gladly take it. I am tired of being a very poor paramedic and working my life away. I don't use a lot of words on my slides. I hate slideshows in the sense of they just get word vomit on them and you don't get a lot out of them. So I use small phrases or single words. I'm a very interactive speaker. I like to talk to people. I like to engage them. So please, as things go on, have the comments coming. So a couple quick objectives here. Just by the end of this session, you'll be able to know the difference between like some high fidelity equipment versus a high fidelity environment and know some of the benefits and drawbacks of those. You guys will be able to have some strategies on how to make an environment high fidelity without necessarily a lot of high tech. And you guys will be able to apply some of that creativity and resourcefulness that we talk about today to enhance your own education and simulation at your home agencies. So my goal for today is to not give you a framework of how to build simulation at your agency or teach you how to do simulation, or necessarily how to set up that. My goal today is to allow you to take the basic things that you have and put that into an ambulance and create mobile simulation that you can take out to your stations, out to your people, or if you're only like to have a single station, a group where you can put people in the ambulance. And we're talking about some of the resources and things that we have today. And I just want you guys to take from this today on what are some cost-effective and easy ways that we can do that. And people look at simulation as a very daunting task and they often overthink it. So, a question I present to the group here is what is simulation? When we hear that word in regards to EMS and education, what is simulation? And feel free to put some answers in the chat. So, while people are hopefully putting stuff in the chat, is this simulation? Super high tech, virtual reality, all of those things. Is that what we think simulation is? Okay. Carrie put a modality of teaching that's proven to improve patient outcomes. Jennifer puts hands-on training. Okay. I agree with both of those. Or the simulation look like this. And as you guys chuckle a little bit about this picture, one of the things that you can notice is this guy's ready to intubate, but he has the ET tube on the bougie upside down. And this is an AEMT that he's a paramedic now that he was in paramedic school when we were doing some solid training and he was all excited that he was going to get this tube and he knew what he was doing. And I kind of had to tap him on the shoulder after I took this picture and be like, probably not going to get that ET tube there, pal. And like this was a very low tech simulation. We had a Fred the Head, we had a piece of PVC pipe, we had a small drill pump, and we had a lot of like jello sludge for vomitus and stuff that we put in the airway, and we had large bore suction. And just in doing this, he didn't do a good intubation pre-check. He didn't, check it. He just grabbed his stuff and he's like, man, I got this. And that was the result. And, this picture isn't staged. That's as candid could be. And he's just all excited. And I got to burst his bubble a little bit. And we had a good laugh, but something super simple and easy that allowed us to identify an issue right there at the very start. Okay, I like this. Computers, mannequin-based, high-low, standardized patients, task trainers, screen-based. No, all of this I agree. A means of creating training through hands-on approach. So, um, the Society for Simulation in Healthcare actually has a dictionary for simulation-based items in a standardized terminology. That's a really great resource to use. And the reason they made it is they're trying to create standardization of terms that we use across the board. And, so I got their definition of, simulation is a technique that creates a simulation or environment to allow a person to experience a representation of the real event, purpose, practice, learning, evaluation, testing, or to gain understanding of systems or human actions. Now, I read that off not because I like reading slides, but to kind of give that overview of simulation at its core. Absolutely, Carson. When we get towards the end of the simulation, there'll be a book. I actually have a picture of the book that you guys can have that will show you guys where to get it. But when we look at simulation, we really need to understand that what are we trying to accomplish with simulation? What are we trying to do? What are the things that we're trying to get out of it? And one of the big things to me and a lot of colleagues that I've worked with is that we want to make people feel like they were there. We want to immersify them in the environment because that's where the true learning is going to happen. I can take like that salad mannequin. That was a good little simulation we did for difficult airways, or you can have test trainers and you can set them up. But the simulation piece itself is every part of it. It's more than just a task trainer. It's more than just, a Fred the head. It's more than a single piece of equipment. The simulation is everything that goes into it from your scenario, your evaluators, patient actors, if you have them. It's everything that goes into it to put the person that we're teaching into that situation to make them feel like they're there. So that brings me to my next question for you guys of what's more important, high fidelity equipment or a high fidelity environment? What do we think? Anybody want to put anything in the chat? No, not necessarily. Well, okay, I see loaded question. I see why not both. And it can be both. I do agree, but traditionally, in my experience and what I've seen and read, is that the environment is really the key piece there. And oh, that's a good one, William. The objective. What are we trying to achieve with the scenario, right? So when we think of the basis of this class, especially of rule simulation and underfunded education when it comes to EMS, environment especially is the most important part. And it's the most important part because high fidelity mannequins are great. Like the Laerdal 3G SimMan Plus is awesome. It bleeds, it pees, it sweats, it cries, it does all these awesome things. But there's also a lot of drawbacks with that high fidelity mannequin that you can't do to it. You can't start IVs on it. You can't do other basic tools with it. And they're really finicky and you got to be careful with them. And there's a lot of education that goes into running them properly and understanding the software. And they break real easy. I know they say they're durable, but like a lot of those high fidelity mannequins, depending on the brand, all of them can break pretty easily if we're a little rough on them. So when you're looking at getting the most out of a situation and the most out of what we're doing, a high fidelity environment will really put you in the mindset versus that equipment. I will take a very low tech situation in a room with a patient actor that's really good at acting on, like, say, a psych call that just has random stuff scattered around to create that scene that has no tech versus you having a high piece of, a high dollar piece of technology there that can do these things too. But yes, I think one of the big things is what is our goal and our objective from it? And for the, precipice of this lecture, it's do we have that type of funding to do it? Because when you look at those type of equipment, you're looking, 100,000 plus dollars to get something like that versus, you know, 10 to 30 for some more lower tech stuff. So the environment is really the key piece there. And you guys hit on a lot of stuff there. Like, so let's talk about this moving into what are the benefits of both? We talked a little bit about the environment and the benefit from it, but what do you guys think the benefits of having a high fidelity piece of equipment? What do we think we can take from that? Take some realism from it. A thing that comes to mind when you guys talk about using both environment and equipment is take that Laerdal mannequin, you know, and you put them in a trauma situation. That mannequin can bleed. You can put tourniquets on it. You can pack wounds with it. Does a lot of real good stuff there with that piece of equipment. But to flip that too, you can take a low fidelity mannequin, um, and with some creativity, you can make it bleed. You can pack the wound on it, and you can do those same things. But I agree, it can give you a much more realistic feel to the situation that's going on. But one of the things I'm going to challenge you guys with today, and that I want you guys to be thinking about, is how can we do those things without the high fidelity equipment and solely the environment that we have to make for ourselves? So let's talk about that a little bit and go move into the drawbacks. And we've hit a couple of those already, is that, some of the drawbacks are that high fidelity equipment's experience is expensive. Not only is it expensive, it requires a lot of extra training sometimes. But to low fidelity equipment and looking at solely the environment, you lose out on some of that realism and the realistic feel that you would get with a high fidelity or a medium fidelity mannequin that said that, maybe you're just using a standardized, static type patient mannequin. So you really got to evaluate what resources you have at your agency and how you can utilize them. And, how can we take that and put it in an ambulance and take it out to people? Some thoughts as we go through this, and we'll discuss some more in depth. So ultimately, when we look at it as a whole, not an environment or a piece of equipment, what is our goal with high fidelity simulation? We've talked about, pros and cons of each. We've talked about what simulation is. So what really is our goal when we go and we take a clinician and we put them in that simulation? What are we trying to achieve? And while it may vary some per agency, ideally we all have the same goal at the end of the day. So what is that? So the goal that we're trying to achieve is that we want to ensure that when our providers look in to these situations, that if they would then experience it out in the field in real life, they would be able to handle it. When we look at doing simulation and we're looking at it from an education standpoint, we're really trying to affect cognitive, psychomotor, and affective domains all at once. And the one that we're probably really hitting more than anything is the affective domain. And the reason I say the affective domain is that if you can create that environment and make that provider feel like they would out in the real world, regardless of how tech it is, that's the goal that we're trying to achieve. Because that way, when they go out and they do face that situation in real life, and they start to feel that, it won't be unknown to them. It won't be taboo. It won't be weird. And they won't, hopefully, they won't panic or freak out or lose what they're supposed to do. So these are all things that we need to think about when we look at our goals in this regard. So, we talked about, sorry there, my computer had a seizure. When we talk about high fidelity environments, you take a mannequin, you throw it outside, and then you let a provider work. This is a picture of a drill that we did of an active shooter training. Ooh, thank you for putting that. And this was this active shooter training that we did with local law enforcement, fire, and us in one of our coverage areas. And we were part of this response. EMS staged outside. They would wait for law enforcement to clear and bring out casualties. And when they were brought to us, had our staging area, we had our equipment, and you had this static mannequin, you had a rhythm generator, you had an LP-15, and you had all of our equipment. And when you look at this, that's a pretty decent situation. The only thing that we were really missing in this is doing some good moulage, and that is a lost art in of itself. And it was an amazing learning opportunity for us, for law enforcement, and for fire. One, to learn our roles in these situations because we don't practice them a lot. But two, how do we perform in those situations? And there was very low tech involved with this, right? It was, some toy guns for law enforcement. Fire just had their apparatus and their marking pieces of equipment to mark off zones. And we just had training equipment and the static mannequin. And that was hooked to a rhythm generator. And she was trying for an airway. She struggled with the airway, so she went to an eye gel. And it's all these different things that you can do, and it not only teaches us how to care for a patient, but it also how do we talk to law enforcement? How do we talk to fire? What are our roles? What are the briefing things that we need to talk about before we go into an event? And as far as equipment goes, it was very low tech with that. But putting somebody outside in the heat and making them work on a patient in a staging area, that did a lot for the providers that were involved. So here's another one. This is a scenario that we set up for uh, some of our critical care folk that were doing some competencies. And that's a regular static mannequin that it was an old Laerdal 3G, but it had long since lived past its prime, and we use it for a static mannequin. And we have central line coming out. We have a makeshift central line coming out of his neck. He's got IV drips going. He's got a monitor there with the iSimulate. We used one of our spare Hamiltons. You know, we have all of our bags of equipment. And when you look at someone doing a critical care transport, while there is some medium technology in there, like the iSimulate, when you compare using that with the static mannequin versus a Laerdal, the cost savings that you get on that and able to put it in your ambulance and do anything you need to with it are key. Because now, where that's just being used as a static mannequin, say we wanted to do that in a trauma situation, we can throw him out on the ground, we can make him bleed, you know, and we're going to talk about how you can do that with a static mannequin that may not necessarily do it. But it's all about that environment and making those learners and clinicians feel that pressure and that emotion that comes from it. Because I know everybody on this call has dealt with that person that, man, they're really smart and they can do stuff, but when they get out in the field, they just can't get it from their head to their hands. And I strongly believe that the reason they can't do that is a missing opportunity of the affected domain, and that they don't have the emotional confidence or the emotional intelligence to be like, I can do this. I know how to do this. And that goes a long way with the type of work that we do, regardless if it's EMS, if it's critical care, whatever your background is in healthcare. Knowing how to do it and being able to do it are only part of that battle. But having the confidence and the ability to do it and knowing how to regulate those emotions in the situation is just as important sometimes, if not a little more. And that's like with the active shooter situation and this one, we had those providers sweating. And it was because they had to think critically, they had to act, they had to go through the motions. And it wasn't like you could verbalize a little here or there. Anything that could be done to those mannequins that was required in that simulation was had to be done. There was no talking it out, there was no verbalizing. And that's some of the stuff that we can do to really immerse our clinicians in this. So, couple examples that I've shown you. So, now that we've seen a little bit of that, how do we create that high fidelity environment? What are some thoughts from you guys that we could do to create it? And feel free to talk amongst yourselves, put it in the chat and stuff, you know, because when we look at, here's this, mannequin, here's this, I simulate, here's this cardiac monitor and a rhythm generator, whatever it is you're using, this is kind of what it feels like for my Disney lovers out there. It's phenomenal cosmic power, and you're like itty bitty living space because you have all this potential and all this ability to do great things. But the problem we run into is we are often siloed and don't necessarily know what to do with the training. And that's the whole purpose behind this talk is what can we do with it? And as we look, let's talk about creating that environment. We'll go back to this guy or we'll go back to here, and it doesn't take much. It takes small things. I've learned, and I'm sure most of you guys have too, is that people tend to overcomplicate things sometimes. We want it to be this big, huge, in-depth, thing, but then we get lost in the weeds of it and we struggle sometimes creating it. And we're like, well, now we got to worry about this or this. And really, you have your scenario. And if it's a solid scenario that you had reviewed and works, lay out your stuff and let the scenario take its own life. Because in reality, the call is going to take its own life and go the direction it goes. And we don't let providers actively harm patients in simulation, right? We like to end it if they start doing dangerous things. But I do like to let them practice clinical judgment and letting them go through that decision-making process of, is this the right decision? Is this the wrong decision? And I will let them kind of go down that route and let them start erring on that side of they may not be making the right choices. And then the patient will decompensate a little bit and see if they catch it. But if they don't, then the scenario ends. But we need to let the scenario take its own life. So let's create an environment. So, this can easily be done in an ambulance. This can be done in an aircraft, what have you. But you want to do an intubation station, right? And say you're working with night shifters. And I don't know who here does critical care too, but you're trying to do intubation in the back of an aircraft on night shift. And if you've never done that before in flight, it sucks. It's not the greatest thing in the world. It's doable, but it sucks. So people are like, well, we can't recreate that. And how can we do that? And it's really simple. You need your aircraft, you need a helmet, a pair of NVGs, and an airway mannequin. You put the airway mannequin on the sled, have your clinician put their helmet on, have them mount the NVGs on top, and have them intubate the mannequin in the dark. And like turn on the low vis lights in the back of the ambulance. And that's as simple as it gets. And that's as low tech as it gets too. But you've created a high fidelity environment. Like outside of starting the aircraft up and getting the noise and the vibration, which you could do that with sound equipment, you've created the situation in which they would have to intubate that patient. And you can make it as simple or as complex as you want from that point forward. But you need 4 pieces of equipment outside of an intubation role: a helmet, a pair of NVGs, an airway mannequin, and an aircraft. Take that same concept with an ambulance. You want to do an airway in the back of an ambulance. Cool. Throw a couple people in there, throw a mannequin in there, have people rock the sides of it. If you have the ability to, and you have the area, have them drive it around the parking lot. Let them simulate some of that movement and those bumps and some of the road noise. The sky is really the limit with this. And we're only limited by us and our imagination and what we're willing to do and what we're willing to work towards. And before I, continue on, do we have any questions? Like normally my chat feed is a lot more active than this. I'm not used to it not having a lot of activity. So do we have any questions? Do we agree? Do we disagree? Like, what are we thinking? You know, yeah, we have to be creative. Like we are our own worst enemies. And sometimes simulation is as easy as you saw that picture. Four small, three pieces of equipment and a space. Sometimes it is that easy. However, sometimes it's not. Sometimes it takes a whole bunch of people. And simulation work is not easy. It's not easy when you're really funded. It's definitely not easy when you're underfunded. So you got to really have that love and that passion and that drive for simulation, especially in rural environments. And I come from rural West Virginia. You know, like my high school graduating class had like 75 people in it. And so small town USA is my life, my passion. And we had none of this when I was coming up in EMS. And I wish I knew half of what I knew now, or had somebody that had this passion to pioneer and bring simulation forward. So, how do we do it? What resources should we use? And to put it simply, if you have an old ambulance that's a spare or, you may be decommissioning, that's your simulation truck. That's the resource primarily that we need to use. We don't have a brand like the agency I work for now, we don't have a brand new ambulance. We have a retired box unit, a type 1 that's been retired that we have now converted into our sim ambulance. And it was the setup that you saw in the back on the one with the I simulate the static mannequin. And we've done all kinds of things with it. And so you take your ambulance, you take your expired equipment, and you stock that ambulance like you would just your normal regular 911 truck. If you have spare bags that match what you guys are using, stock those bags with the way they need to be. Make that simulation area, unit, whatever it is, as close to real as what your providers use day in and day out. Because you want them to practice in real life the same way that you train, right? Fight like you train, train like you fight. And if we're just using haphazard bags or things we've thrown together, that doesn't help us. Yes, Kim, absolutely. If you're not good with label makers, you will be by the end of doing simulation. Um, and if you want to get real creative and you have the additional funds, maybe even get that truck restickered to show that, this is a sim ambulance. This is for simulation only. And that's the sole purpose of this truck. But that way, when you do have your bags and you have your equipment and you get in the back of that truck, oh, bam, this is exactly like in real life. And that is a great way to get started. And yes, we absolutely should be using the healthcare simulation best practices. Like we should be doing what the standard calls for. And EMS is a different beast as a whole, though, when it comes to this, because we don't have a lot of that technology. We don't have a lot of the resources. And honestly, a lot of people don't know what it is or how to find it. I didn't know what the Society in Simulation and Healthcare was until last year or until this past August. when I attended a NAEMSE conference. I had no idea what it was, and I took one of their courses there. And it's a credible resource, and I've learned so much in a short time about it. And so that's the first step. The second step is now that we have that dedicated piece of equipment that we've put our expired stuff on, we've labeled it appropriately. Now you can really do some fun stuff with it. And depending on what you can do, how you should do it, the sky's the limit there. And unfortunately, it's if only we had a simulation book for dummies. And the problem is, do we or do we not? Well, good news, everyone. There are a few actually. And they're really great resources. The first one is Defining Excellence in Simulation Programs. Second one is Comprehensive Healthcare Simulation. And the third is the Healthcare Simulation Dictionary. And someone was asking about what that dictionary was, where I got the simulation definition from. It's this one right here, Healthcare Simulation Dictionary. These three books are incredible to use. I have bought the first two books, and I have a copy of the Healthcare Simulation Dictionary too. And the Healthcare Simulation Dictionary is free on the Society of Simulation and Healthcare's website. It's a great resource to use, and I use it daily. In the two other books, Defining Excellence in Simulation Programs even has a section on how to do mobile simulation, the type of ambulance you need, how long it should last, everything that needs to go into it, and you can tailor it based off that. And a lot of stuff that I do, how I teach, how I go through this is based off these three resources here. And I'm not endorsing any product by any means, but they are good resources to use. And they have helped me a lot along the way. So those are the things that we need to look at and how to do them. And we talk about, what all can we do with it? And that brings us into the next slide here. That's going to be a really, strong talking point is simulation is an art. It is truly an art form that is not for everybody. Not everybody is able to do it. And but I also believe that if you're not able to do it, is it something that you truly have done your all for? Have you put your heart into it? I used to like simulation when I first became an EMS educator, and I was like, this is cool. Here's a task trainer. Here's a scenario. This is simulation. And and then I realized all the work it was. And then I was like, oh, I don't know if this is for me. And then I advanced myself as an educator and a clinician and was like, no, this is what we need to do, and this is how we do it. So take that ambulance now, and we need to go to a station in a rural area. Like I'll use my old area. I covered our agency covered 4 counties in the southern part of the state of West Virginia, and everybody lived in different counties. So you can imagine trying to get a centralized location for education and training was damn near impossible. This is a perfect example for that. Is that you need to do some training. Say you need to do ACLS, PALS, trauma, like anything, it doesn't matter. Now you can take that ambulance out to them and say you're doing a PHTLS class or you're doing an ACLS class and you're doing that out of hospital scenario for that chest pain patient. Cool. Set that patient up in your station, have them go through the process of assessing on scene, going through it, even uses, if you want to have someone play the patient, all the way up to loading them into the truck, doing treatments and everything. And once again, take that static mannequin, your equipment, and the iSimulate, and that's all you need. You can do all that stuff in the resident station, doctor's office, whatever it is you choose. Load the patient onto a stretcher and out into the ambulance they go to do their treatment and transport. Same thing with a trauma patient. Take that patient and put them on the asphalt somewhere and, under a car or, something like that you can stage, or they fell on the sidewalk at your station. Make them work the patient there. Bring the patient in the truck. Practice loading and moving. It doesn't take much. And we can really dive in to those domains of learning and really reach our clinicians to provide better patient outcomes when they get in the field. Because I wish some of the calls that I had as a young EMT and as a young medic that I'd have had simulation on. Like my second call as an ALS provider was with Parkinson's White. What I had a 15-year-old with it. Like I wasn't prepared for that. I was told in paramedic school that providers never see it, in their career sometimes. And I saw it twice in 3 years, and it was the same patient. So I wasn't prepared for stuff like that. Like, yeah, I knew how to treat it, I knew what to do, but like that emotional aspect of like, oh no, here it is. That's so important. So we've talked about a lot of stuff. We've talked about creativity and being what it takes to do simulation, but what else? What else do we think it really takes to do simulation? I love that Carrie's posting all these resources in here for everybody too. This is great. So what do we think? Outside of creativity, you need objectives, right? What are we wanting to do? What is that type of simulation supposed to achieve, right? What is our goal that we're working for? Do we have an initial certification class that we're just trying to teach people how to do basic assessments? Do we do we teach people that, are we looking at like a tenured provider that's just doing some con ed? Or are we talking about an orientee that's trying to get cleared to go work out in the field? So we need to know our objectives. Then we need to be creative. We need to use imagination. And when it comes to simulation and getting the things we need and doing it, there's another aspect of this that we don't talk about is what are those processes? How do we work through the minutia, the politics and everything from it to create it? Does anybody know how to do that? I sure didn't when I first started. And most people don't either. But we have to learn those processes and we have to learn to work through it. And William, that's brings me perfectly into my next slide. It takes tenacity. We just have to do it. And if it sucks or it fails, cool. We've learned something. Maybe it was the objectives that didn't really match up to the scenario. Maybe the scenario, even though four people read it and was like, yeah, man, this works, it's great, it completely sucked. Maybe that you thought all your stuff was charged and then come to find out the day of, none of it was charged. But we have to be tenacious and we can't quit. If you have a good idea, the people that you work with like it, they want to do it, try it. Worst is worst thing that can happen is that it doesn't work. And then we go back to the drawing board. Like my team here hates it when I write scenarios because they know that for the next day or two, I'm going to be making them read it. And then I'm going to change what they say. And then I'm going to make them read it again. And then we're just going to go do it. So we can't be afraid to push that envelope when it comes to this. And if this isn't something you've done at your agency and you're just trying to start implementation of it, your providers are going to push back. You're going to have some that love it and are like, man, this is what we're wanting. This is great. This is awesome. But you're also going to have providers that are like, why are we doing this? And they're going to push back against it. And they're going to demand justification because when we start doing simulation, real simulation, and we have objectives, we have criteria, and we grade people and we work through it, that's going to start holding providers accountable. And you're going to start getting, well, if this was in the field, I'd have done it, or if it was this, or if it was that. And they're going to have to face some realities that maybe they're not as good as they thought they were. And that's going to be on you guys too to help mitigate and manage. So that's why I say this is not for the weak of heart. And we have to have a strong backbone with it to be able like, no, this is what it was. And make sure that we're getting our medical directors involved. Because like I'm fortunate, we have very involved medical directors here and we have multiple, and they're all involved in this. And they get involved with the providers and they get involved with the creation. And But none of that happened until a small group of us was like, no, this is what we're doing and this is what we want to do. We have a mission statement with our agency that says this. This is how we're going to meet that with our providers. So we can't be afraid, and we can't be afraid to push back when we get pushed back. So tenacity is something that we all have to have when it comes to creating simulation. And the thing about it is, is that simulation is all in what we make it, good, bad, indifferent. If we put in quality work, quality time, even the lowest tech and lowest fidelity will still be a good simulation because we have put real work in it to show that we want our providers to gain something from this based on whatever that criteria is in order for them to have better clinical outcomes when they go out in the field, experience a new procedure, a new protocol, what have you. An example I use is, on a critical care side, we just got thoracostomies, orthotomies, and we can do that in the field now for our trauma patients. We did some serious in-depth simulation on how to do that, and honestly, without it, I would be terrified to go do it in the field. And even now, I'm still a little nervous to go do it out in the field. But it's because of that thought process, medical director involvement, educator involvement, that when it happens that I need to do it, I'm going to do it. And while I'll be nervous, sure, but I've already experienced that sensation through simulation. So it's not new, it's not taboo. And I'll be able to work through it more. And that's really where you start hitting the affective domain. And then that will then correlate to your cognitive and your psychomotor and allowing you to get from here to here when you go out and do it in the field. And no matter what happens, when you are stressed and you're just done, remember the goal. Because I don't know about you guys or the systems you work at, but you know, everything's a fight. Everything's an uphill battle. And if you guys don't work for an agency like that, and it's nothing against any agency, it's just how it works, right? There's always people competing for money. There's always people competing for time. There's never enough of it. And we always want instant results and we want things fast and we want things cheap. And that's just not how life works. So you're going to get bogged down. You're going to get stressed. And working in rural environments, that's going to happen a lot. But remember, if you are in that rural environment and it's your family members or it's that small town community and you're 45 minutes to an hour away from the hospital that we're going to be transporting to, remember the goal, that our goal is to create that simulated experience to make that provider understand and feel and work in that stressful environment so that when they get it in the field, they can do that. And that way, when they go get your mother, father, brother, sister, family, friend, dog, whatever, they are able to do so. And you can see that they've done it and have that confidence in them as well. And that's the goal to all this, or at least to me, that's the goal to all of it, is that when we see it all come full circle, that that provider was struggling with something or they were learning something new, they do it in sim, they learn, they have the aha moment, and then we see them do it in the field and they did it correctly and they did it with pride and they did it with confidence. That's the goal. And for an educator, there's, in my mind, there's nothing better than seeing that come full circle. And that's why, part of the top title of this topic is, do you have what it takes? Because simulation, especially rule simulation, is not for the faint of heart. It's not for the weak-minded or the weak-willed. It takes a lot of work. And, that's the things we have to remember. So we are coming to a close and we are a little bit early. Um, I was expecting a little more interaction. So, but no questions. We have about probably 10-ish minutes or so. Please come at me with some questions. I do not care to break anything down, talk some more about it. If there's a specific slide or resource that you want to go back to, we'll talk more about it. So please. Thank you, Carlene. And to those in the chat that have been talking and giving resources and talking back and forth, I do appreciate you guys. It was some really good resources and good talking points. I always like the engagement. It kind of helps the presentation go a little smoother and gives more life to it. We can, Kim. Is there something specific that you're wanting to discuss? I think I pulled down my. Yeah, so when we talk about, those standards and we look at, best practices and what they are and why we should use them, is that, one of the reasons I'll use the dictionary, for example, is that one of the reasons that they're there and we should use them is it's like anything else when we talk about, care and education. We want to make sure that what we're doing is the same that anyone else would do at the level that we are across the board. And we look at that with the standard of care for EMTs, AEMTs, paramedics, the same concept applies when we do simulation. And, it should be done, and why it should be done is that when you take a simulation and we do it at X agency, right? And then we go to Y agency, that simulation should essentially be held to the same standard and run through the same process, even though the proctors may run it a bit differently. It essentially should have the same goals, same outcomes, and everything else because simulation, as great as it is, can also be really dangerous because we don't want to put providers in a simulation that teaches them or shows them bad things. That's why I said at the beginning, earlier on in this, that we don't let providers injure patients throughout their scenario. Once they start going down that path, we end the scenario. And that's why standards like this are in place is to prevent things like that from happening. Is because once you let that provider work completely through that process and go down that wrong path, part of them thinks they were doing right and that the patient just didn't have a good outcome. And that they may take the wrong information from it that they don't need to. And then they may go do that out in the field. And they may see that patient scenario out in real life, treat the patient the way they did in simulation, and then patient die. And we should have ended the simulation there and debriefed with them versus letting them play it out. And when we talk about simulation and how we do it, every simulation should be done in the exact same framework every time, right? You should have your pre-brief with your team. You should have your pre-brief with your clinician, your scenario, your debrief with your clinicians, and then your debrief with your team so that you guys can all be on that same page of what it's going to be, how it's going to go for your team. What are our key stopping points was also should be in your scenario. And what are we looking for to grade? And how are we grading? And, you know, there are great rubrics that you can use, and some of them I even got from Kim and a couple others at NAEMSE on what you should be grading as far as clinical, you know, standards are. We should not be pulling arbitrary numbers. We shouldn't be pulling arbitrary things out. They need to relate back to what it is we're doing. And there's multiple different, rubrics out there. There's multiple different grading criteria that you can use. But that's why these standards are important, is so that everything is being evaluated the same way. That way, when you evaluate your provider A and provider B, they're having the same grading criteria and they need to relate back to something. They don't need to be like, okay, criteria A, 5 points if this, 4 points if that, 3 points if that, and they have no relation to what's going on. You know, 5 points for protocol adherence. Like what are they reaching back to that we can actually quantify to pull real data from when it comes to evaluating and looking at what we're doing? So when we think those standards and best practice, that's where a lot of this come from and why we should use them and why they're there is so that we don't get lost in that. Because like everybody thinks they're doing the right thing until someone tells them that they're not. And these standards help us keep us honest and keep us where we need to be. So if you've not read, like healthcare, the standards of healthcare simulation for best practice is something you definitely need to start looking through and incorporating it into what you do. And like then the two books and the three books that I reference are really great at giving out that information, how to set it up, standardizing terminology. It makes everything so much more smooth when going through it. And then if you're ever audited or evaluated or someone starts asking questions and your training gets pulled into play, here's the foundation that you can, protect yourself with of, well, I follow these simulation standard guidelines that are produced by this agency. Here's our grading rubric that does that. Here's this that does that. And it defends you in the long run, but it also gives you the foundation to build a solid simulation program regardless of where you're located at. Sure. One second. So give me one second. We'll have the books again. So here are the books again. Kim, did that accomplish?